the organizing committee for inviting me again for the second time for East Coast Anesthesia and Intensive Care Conference. I'm honored to be here, and possibly I'm among the chosen speakers to give a talk at 2:30 onwards, and I think the audience also the chosen one to be sitting here and listening to me and Associate Professor Dr. Saniha. It is indeed an important topic to be presented. Back 2019, the first East Coast Conference, I was given the topic of the update of traumatic brain injury. And I give up to the organizers to give me the topic and then giving me the evolving practice in managing traumatic brain injury. So when I start preparing the topic, I think it's a quite big topic itself and can be a plenary session, or can be a session, one whole session to talk so many aspects of traumatic brain injury. Okay, let's start with traumatic brain injury management. We cannot avoid from talking about Brain Trauma Foundation guidelines. So Brain Trauma Foundation guidelines, the latest one is 4th edition. This is the guideline by Brain Trauma Foundation, supported by American Association of Neurological Surgeons and the Congress of Neurosurgeons. This is actually the collection of evidence based on management of traumatic brain injury, and but the evidence, the latest evidence, is actually back in 2014. To say they're quite outdated, but this is but all the evidences and recommended by Brain Trauma Foundation has been referred by most of the physicians for the management of traumatic brain injury. So because the last back in 2019, I have elaborated a lot on these Brain Trauma Foundation guidelines. So we just going to touch a little bit because I want to talk what is the update after that. Okay, so Brain Trauma Foundation guideline, they come out with recommendation 1, 2A, 2B, and 3, and the highest number, where is the level 1, is actually the highest quality body of evidence. So just a recap of what is the guideline is all about. You can download and visit the website of Brain Trauma Foundation guideline. So the contents, okay, we will revisit these Brain Trauma Foundation guidelines, and I will touch a little bit on the few aspects of the management. This is the list. Then I will stop when the bell ringing, because I know I won't be able to finish, but I will touch a little bit on that, and I open to the question. So we're going to talk about decompressive cranectomy, seizure prophylaxis, sedation, hypoosmolar therapy, hypothermia, barbiturate coma therapy, mechanical ventilation, and some protocol-based management. So back based on Trauma Foundation guideline, we're looking at decompressive cranectomy. They put the evidence, the recommendation at 2A with quite a moderate quality of evidence, and the recommendation is this procedure has been demonstrated to reduce ICP and to minimize days in the intensive care unit. And the second recommendation, a large frontotemporal parietal decompressive cranectomy is recommended over a small frontal parietal. So this is a 2 recommendation. So after that, the update from this guideline, during the guideline came out in 2016. This study, the 2 studies was still going on and has been completed, and the updated one, the updated version of this study in the Brain Trauma Foundation guideline published in this article. So in 2022, the update on decompressive cranectomy chapter presented here integrate the findings of rescue ICP study as well as the published 12-month outcome data from DECRA. So these 2 studies actually looking at the outcome of decompressive cranectomy to the management of traumatic brain injury. So from these 2 big studies, actually the recommendation for decompressive cranectomy, they added 3 new ones. Okay, so still the level at 2A, to improve the mortality and overall outcome. So the new additional in this the guideline, the secondary decompressive cranectomy performed for late refractory ICP elevation is recommended to improve mortality and overall outcome. So you got the early and the second decompressive cranectomy when indicated. So this is level 2A recommendation. Another one is that secondary decompressive craniectomy performed for early refractory ICP elevation is not recommended to improve mortality and favorable outcome. So the late refractory is recommended to improve the mortality and favorable outcomes. It is actually more to the neurosurgeon, but at the same time, we together managing and the decision made for us to facilitate this process. And another additional one is the fourth, the third new edition of this on this topic is on the ICP control. So the statement is that the secondary decompressive craniectomy performed as a treatment for either early or late refractory ICP elevation is suggested to reduce ICP and duration of intensive care, though the relationship between this effect and favorable outcome is uncertain. So this is actually the three updated in the Brain Trauma Foundation guideline on decompressive craniectomy. Okay. Now the next we look at the seizure prophylaxis. So based on Brain Trauma Foundation guideline stated that prophylactic use of phenytoin or valproate is not recommended for preventing the late post-traumatic seizures. Okay. Phenytoin is recommended to decrease the incidence of early. So the recommendation is actually to start phenytoin to cover for early post-traumatic seizures and not for late post-traumatic seizures. We can see that normally when the traumatic brain injury is always phenytoin has been started to cover for early post-traumatic seizures within 7 days. Okay, so now come the newer anti-convulsant, which is levetiracetam, has been become an alternative, a good alternative for phenytoin. The advantages of levetiracetam or Keppra got less side effects, especially lower toxicity, less drug interaction, because this drug is not enzyme inducer and enzyme inhibitor, not an enzyme inhibitor, less dose monitoring, achieve therapeutic level faster, broader therapeutic index, and less cutaneous reaction. If we compare to phenytoin, you can see after 5-7 days, you can see the liver impairment, especially in the patient on phenytoin. And some very severe condition, you can develop Stevens-Johnson syndrome. So you can see the few. I just show one of the studies looking at the effectiveness of anti-seizure medication therapy in preventing seizures in brain injury patients. So this is actually looking at a systemic review, looking at total of 7 randomized controlled trial. They want to see to explore the effectiveness of different anti-seizure medications in preventing early and late post-traumatic epilepsy. Okay, we just look at the conclusion of this study. They look at the levetiracetam and phenytoin prevented early and late, so it is beneficial for late post-traumatic epilepsy as well. And phenytoin also reduced the mortality rate in patients with TBI. Both levetiracetam and phenytoin had higher treatment-related adverse effects compared with placebo. However, levetiracetam had slightly lower incidence of treatment-related adverse effects when compared with phenytoin. So if compared to placebo, definitely it's more higher side effects. But the benefit wave of the complication of that when we're starting both of these two medications for post-traumatic seizures and looking at the levetiracetam had slightly lower incidence of treatment-related adverse effects when compared to phenytoin. When compared with phenytoin, levetiracetam did not reduce the length of hospital stay but shortened the length of ICU stay. Therefore, the recommendation from this study, based on the findings of this meta-analysis, we speculate that levetiracetam is the best treatment option for TBI patients. Some centers has shifted from phenytoin to levetiracetam. Next, we move to sedation and analgesia for the management of TBI. So from Brain Trauma Foundation, BTF 2016, I just highlighted on propofol, okay, because we will talk about it later. So from the previous recommendation, although propofol is recommended for the control of ICP, it is not recommended for improvement in mortality or 6-month outcome. Okay, caution is required as high-dose propofol can produce significant morbidity. So propofol is recommended to control the ICP. So most of the center, there's one paper looking at the looking at the usage of sedation and analgesia in neurotrauma patients. Most of the center use propofol and with combination of fentanyl. So what is the, looking at the ideal properties of sedation and analgesia in traumatic brain injury, we need the agent with fast onset, fast offset, good cerebroprotective properties with reduction of cerebral flow, reduction of CMRO2, and reduction of ICP. It should have anticonvulsive properties, hemodynamically stable and able to maintain CPP between 60 to 70 mm mercury, avoiding fluctuation of ICP, facilitate neurological wake-up test. This is one of the important things. We always talk wake-up test last time in old school during spine surgery. Now the terminology is neurological wake-up test is very important because they want to assess GCS and neurological function of the patient without the masking effect of sedative agents. And then maintain cerebral autoregulation, maintain cerebral vascular reactivity, facilitate mechanical ventilation, anxiolysis, and prevent agitation. So it can be the ideal properties specifically for neuro and as well for general ideal properties for sedation in ventilated patient. As we know, just a revision, you can see the context-sensitive half-time for propofol and remifentanil is the shortest one. Okay, you can see midazolam is longer, so context-sensitive half-life is dependent on the duration of infusion of the sedative agent. Then we can see that it's a propofol. When we're talking about cerebral protective, so we look at these the effect of ICP, CPP, cerebral flow, SMRO2. We look at the propofol has the better effects if compared to benzodiazepine. Okay, and barbiturate is almost at similar effect to the ICP, CPP, CBF, and SMRO2. This is just to highlight why for neurological patient and especially the traumatic brain injury, the first line is a sedation is propofol. Because of these ideal properties, and we combine with analgesia. The best to me is we have remifentanil, but if remifentanil is not available, then fentanyl. And looking at this is one of the review article in 2000. This is 2016 on optimizing sedation in patient with acute brain injury. We can see that they're giving that suggested option of sedation. For if no ICP elevation, if elevated ICP, so of targeted temporal management, status epilepticus. So all propofol has been the first line, followed by midazolam can be the option, propofol and fentanyl. Okay, you can see all the listed indication. They put it as propofol and fentanyl as the main sedative agent. Okay, if patient agitated and delirium, they suggested at first line for alpha agonist. Normally we use dexmedetomidine. So if you look at this algorithm in the same article, so you can see that to start with sedation and analgesia with propofol is more preferable than midazolam. So I would like to suggest we always put at least during cerebral protection if we have no limitation to put propofol and for analgesia like remifentanil or fentanyl as the first option of sedation and analgesia in traumatic brain injury. So we move to the topic of hyperosmolar therapy. This is another aspect that always been debatable. Okay, so this hyperosmolar therapy, the recommendation is was included in third edition, but it's not more supported in the fourth edition. Why? Because the evidence is not strong. It's a weak evidence, just based on possibly clinical experience, case report. So although it is not included in the fourth edition, also it has been stated to highlight that we have the evidence has been discussed and highlighted in the third edition. So what has been stated? Although hyperosmolarity may lower intracranial pressure, there was insufficient evidence about effects on clinical outcomes to support a specific recommendation or to support use of any specific hyperosmolar agent for patients with severe traumatic brain injury. And mannitol is effective for control of raised intracranial pressure at doses of 0.25 per kg to 1 gram per kg body weight. And we must make sure avoiding the atrial hypotension. And restrict mannitol use prior to ICP monitoring to patients with sign of transcatheter herniation. So this was the statement from the third edition, right? So we must, for the hyperosmolar therapy, is either sugar or salt. Sugar is mannitol, this is sugar-based. The salt is hypertonic saline therapy. So we know that sugar we got, for the mannitol we got the hyperosmolarity agent with the preparation of 10%, 2%. For hypertonic saline base, you can use the few preparation, 3%, 7.5%, 23%, it depends on the institution. So the differences is that the higher the concentration, the higher osmolarity, the higher sodium content. So possibly the higher concentration, you use the lower volume, the lower concentration, then you use more volume. So at the end, you can use, because it's a variation of practices depend on the institution, right? So if we comparing mannitol and hypertonic saline, okay, there's a bolus dosing guidelines as I mentioned, okay. So for the hypertonic saline, we can give intermittent boluses as well as we can give as an infusion. Okay, there's some center using infusion regimen, but for mannitol we need to give a boluses. So the effectiveness of mannitol may wane with repeated administration. So you should have a limit of giving repeated boluses of mannitol. For hypertonic saline, effective after repeated administration and effective when mannitol efficacy has waned. So normally some of the statement in the field literature like always mention mannitol first. When the effect of mannitol is ineffective, then hypertonic saline comes after the second line of management. So for the augmentation of mean arterial pressure is moderate, but hypertonic saline is part of resuscitation free. So from the initial and hypertonic saline come into the practice, it actually has been used for a trauma, polytrauma patient with a traumatic brain injury as a part of the resuscitation free. Okay. So for the diuretic effects, you know, this is osmotic diuretic and hypertonic saline diuresis through the action of arterial natriuretic factors. So the maximum serum osmolarity can go from mannitol up to 320 milliosmol per liter, but for hypertonic saline it can go up to 360 milliosmol per liter. That's one of the advantages of hypertonic saline. Okay, so the rest is actually the advantage is basically similar. All right. So this is one of the study looking at the hypertonic saline. This study is actually highlighted the superiority of hypertonic saline over mannitol, but there are a few other studies that looking at that inconclusive conclusion of comparison between hypertonic saline and mannitol. So this study actually looking at hypertonic saline and mannitol in reducing intracranial pressure and looking at the effect to both effect the burden of high ICP as well as low CPP in patients with severe traumatic brain injury. This is actually a case control study, and the result from this study, they're looking at the comparison 1-to-1 from 24 hypertonic saline patient matched 1-to-2 with 45 mannitol. Okay, so the result showed that hypertonic saline compared to mannitol, total numbers of days, percentage of days with and the total duration of high ICP and CPP low was significantly lower than the mannitol. Okay, the conclusion that hypertonic saline bolus therapy appears to be superior to mannitol in reduction of combined burden of intracranial hypertension as well as associated hypoperfusion in severe traumatic brain injury. This was one of the study that supported the advantage of hypertonic saline, but I think something that I cannot show here. There's other studies that showed it's not that strong evidence to show that the superiority of hypertonic saline over mannitol. And we're looking at the second tier. This is I'm referring the old articles, but still valid to be referred. And okay, the next therapy on second tier of burst suppression therapy. When you talk about burst suppression therapy, you're talking about the role of barbiturate and hypothermia. So these are two management of inducing burst suppression for as a second tier management in traumatic brain injury. So we focus on the hypothermia management based on Brain Trauma Foundation guideline. Actually, the early we talk about prophylactic. So when you're giving hypothermia as a prophylaxis to high ICP, early or within 2.5 hours short-term 48 hours post-injury prophylactic hypotension is not recommended. This is from Brain Trauma Foundation Guideline 2016. So I just show you, this is quite recent in anesthesia analgesia, just showing the infographic of the effects of hypothermia, the advantage. This top research just to show you that this is one of the management. With hypothermia, we can reduce CMRO2 7% for every 1 degree Celsius. Then you must remember it's a part of neuroprotective management, because reduction of CMRO2 and reduction of oxygen consumption. But at the same time, we must be aware with the complication of hypothermia, with arrhythmia, electrolyte derangement, coagulopathy, and so on. Okay. So this was quite new studies addressing on prophylactic hypothermia on neurological outcome among patients with severe traumatic brain injury, published in very high impact journal JAMA 2018. Okay, but we just zoom to the conclusion. Okay, among the patients with severe traumatic brain injury, early prophylactic hypothermia compared with normothermia did not improve neurological outcomes at 6 months. Still, this study showed even though we give prophylactic hypothermia, it did not improve the outcome at 6 months. And looking at this, the diagram, normally the targeted hypothermic therapy for mild hypothermia, we can use by endovascular cooling. Even though the study did not show the improved outcome, but still takes a part of the management if indicated for our trauma patient. Okay, now we move to discuss on barbiturate coma therapy. And looking at this recommendation is a level 2B, which is moderate quality of evidence based on Brain Trauma Foundation last time, where it was stated that administration of barbiturates to induce burst suppression measured by EEG as prophylaxis against the development of intracranial hypertension is not recommended. If used as a prophylaxis, okay, it's not recommended as a prophylaxis. But high-dose barbiturate administration is recommended to control elevated ICP refractory to maximum standard medical and surgical treatment. Hemodynamic stability is essential before and during barbiturate coma therapy. So it has been used to manage a refractory ICP. Also, what is the burst suppression? Burst suppression is actually the level of fluctuating of hyperactivity of brain activity followed by a resting state intermittently. So if we need to initiate the burst suppression therapy, the best for us to be guided by bispectral index monitoring. You can see burst suppression level is actually at 20. So we can titrate our agent like barbiturate or propofol or etomidate to reach that. So we reach at the burst suppression. So we can use non-invasive monitoring instead of using the multiple electrode of EEG. So this was a systematic review looking at the burst suppression for ICP control. Okay, they're looking at the few studies, and a total of 108 patients were studied from few studies to receiving burst suppression therapy. But the drugs used is not only barbiturate. Okay, this is some study, they use etomidate-based suppressive therapy. So bear in mind, when you talk about burst suppression therapy, it can the drugs that can be chosen is either the common one is barbiturate. Okay, we use tiopental, is our common. But it can use propofol, and some also use etomidate. But you must aware of the potential side effects and complication of all drugs. Okay, so the conclusion from this systematic review, there currently exists both Oxford level 2B and grade 3 evidence to support that achieving burst suppression reduces ICP and also has no effect. This is actually a mix of results, and some showed that burst suppression reduced ICP. There's some studies showed there is no effect on ICP. Just to show one of the case report that we reported in our from our experience, just aware there's so many case report on this issue. When you start barbiturate coma therapy, one of the complications, fatal complication, is a life-threatening dyskalemia. So when you start the initial barbiturate coma therapy, you can see severe and refractory severe hypokalemia. You can achieve potassium can be 1.52. So when you start, if you abruptly terminating the therapy, you can cause a rebound hyperkalemia. That is more dangerous. So whenever we start weaning the barbiturate coma therapy, it should be very gradual, so that even though the increase of potassium can be controlled. Okay, so it can be very severe until affecting the morbidity, sometimes mortality to the patient. Right. Okay, next we talk about ventilation. Okay, ventilation, looking at this recommendation, prolonged prophylactic hyperventilation with partial pressure carbon dioxide of 25 mg mercury or less is not recommended. This is from the previous Brain Trauma Foundation guidelines. Okay, and also mention about hyperventilation is recommended as a temporizing measure for reduction of elevated ICP, and hyperventilation should be avoided during the first 24 hours after injury when CBF is often critically reduced. The evidence is weak on this statement. Okay, that's why it's not stated anymore in the fourth Brain Trauma Foundation guideline. This actually an expert panel conference, okay, back in 2020, quite near, looking at mechanical ventilation in patients with acute brain injury. Recommendation of the European Society of Intensive Care, mentioned and considered. It's quite many aspects of ventilation has been discussed in this article, but I just highlight few on the should we use specific mechanical ventilation setting in patients with acute brain injury. So the consensus recommendation, we recommend that a mechanically ventilated patient with acute brain injury without ARDS who do not have clinically significant ICP elevation, the same level of PEEP should be used in patients without brain injury. So we can use PEEP as a normal patient. This is strong recommendation, but very low evidence in favor. The second one, we recommended that in mechanically ventilated patients with acute brain injury without ARDS who have clinically significant ICP elevation, that is PEEP insensitive patient who do not experience ICP elevation after increase of PEEP, the same level of PEEP should be used. Okay, need to digest the statement. So many terminology. The strong recommendation and no evidence. The third statement, we recommend that in mechanically ventilated patients with concurrent acute brain injury and ARDS who do not have clinically significant ICP elevation, a strategy for lung protective mechanical ventilation should be used. Okay, we can use that. Right. So there's only three important recommendations. So I won't touch this one, okay, because it's a very big recommendation. Right. Another important, it is safe and effective to use non-invasive respiratory support in patients with acute brain injury. The consensus recommendation, we are unable to provide a recommendation on the use of non-invasive positive pressure ventilation in patients with acute brain injury who have hypercapnic or mixed hypercapnic or hypoxemic respiratory insufficiency. No recommendation. Cannot come up with a recommendation because low evidence is in favor. Okay. So in general, we suggest that high flow nasal cannula oxygen therapy may be considered in patients with acute brain injury who have hypoxemic respiratory failure that is refractory to conventional supplemental oxygen. So if a patient is refractory to conventional, so we can use high flow nasal cannula, but the recommendation actually is weak because no evidence. Okay, this is based on consensus, right? So one of the another thing of the extubating patient with brain injury. So what are the criteria we can follow to extubate? Sometimes it's always conflicting whether to extubate or not to extubate. So this is one of the paper addressing on that, okay, on the criteria. So from this paper, extubation success was predicted by younger age, presence of cough, and negative fluid balance rather than GCS score at extubation. The result do not support prolonging the intubation solely for low GCS score in brain injury. So these were few criteria for you to decide. When you look at the good cough reflex, okay, negative balance, okay, and then rather than this study, they do use that GCS per se, okay, and the younger age. But there was another study mentioning we knew that the GCS at least 5 and above, right? Just to highlight the criteria of extubating the traumatic brain injury. Okay, I got a few more minutes. I think it's 1 or 2 minutes. Okay, I just highlight. I cannot elaborate on this. Okay, I want you to search this quite latest article and very useful in our clinical practices. A management algorithm for patients with intracranial pressure monitoring, the Seattle International Severe Traumatic Brain Injury Consensus Conference. Because the weakness of Brain Trauma Foundation They did not come up with algorithm of management. So with this conference, they got consensus discussing with expert panel. They come up with algorithm applying the Brain Trauma Foundation guideline for the management. So I just give a zoom. They got the tier 1, tier 2, tier 3 of the management, quite recent one. So I think we go and search this one, especially to the trainings who are going for the exam. So I just go to this very good articles, addressing on the management is incorporating everything is our clinical basis, how we deal with this. Okay, this is a take-home message. Okay, few more seconds. Laparoscopic cranectomy, secondary decompensative cranectomy is beneficial as indicated condition. Levetiracetam can be used as alternative to phenytoin as seizure prophylaxis. Propofol, fentanyl, and remifentanil is the most recommended for early neuro wake-up test. Hypotonic saline is a good option as hyperosmolar therapy. Prophylactic hypotonic is not proven beneficial. Barbituracomat is still useful for refractory intracranial hypertension, but need to be cautious with dyskinesia side effects. Hypotonic cannula can be considered for hypoxic traumatic brain injury. Patients cannot tolerate conventional, and protocol-based algorithm can be used as current guide for ICD, but bear in mind, protocol-based is the level 3 because it's based on the expert opinion. Right? With that, thank you very much for your kind attention. Thank you.